has a ventriloquist act going today. So he's going to be sitting to the side, and he has Representative Creekmore sitting over here because he's not able to be here tomorrow. So he just wants Sam to fill that role for the next 2 days, and I approve that joyfully. So, but with that, Deborah, would you mind calling the roll?
Please acknowledge by saying present. Senator David Parker.
Here.
Representative Roberson.
Here.
Dr. Baker. Senator Blackwell. Senator Boyd. Senator Bryan. Wendy Clemens. Representative Creekmore.
Here.
Dr. Damon.
Here.
Dr. Etney. Here. Heather Garrett. Dr. Hogue. Dr. Johnson. Sarah Jones. Dr. Medeiros. Representative McGee. Kate McMillan. Heidi Nelson. Representative Scoggin. Linda Stewart. Julie Thornton. Jonathan Trickley.
Here.
John Robert Walker. And Dr. Weir. We have a quorum.
Okay, well, thank you all again. I know some are joining by Zoom or tuning in some different ways here, but I appreciate you all getting together again on the same kind of schedule that we did last time. The first thing I want to do is approve the minutes, and then I'll give a little brief overview of how we're going to do today and tomorrow. I think you're aware of that, but just for the people who are kind of watching or kind of in the audience today, we'll do that. But you should have a copy of the minutes in front of you to look over. You may have already had a chance to look through there from last time. Okay. So if you've had a chance to review, are there any questions, concerns, or corrections that need to be made to the minutes from our last meeting? Seeing none, is there a motion to approve the minutes? We have a motion and a second. Is there a second? Second from Dr. Edney. All in favor of approving the minutes, say aye. Any opposed? Okay, the minutes will be approved. Just to give you an overview of what we tried to do, and I'll give you a little background of it. We have several speakers today. We have a couple of speakers in the morning, and what I wanted to do with in talking to Sam about this here is want to have everybody on the task force also have a few minutes to present, but not have that be the overwhelming kind of presentations that we receive, because I think in our deliberations and our communications, we can communicate a different way than the speakers can. So the goal is to get some good information today and tomorrow morning, and then at about 10 tomorrow, we're going to stop the presenters, and then we can just, in this same forum, I'm giving each member who wants to present 5 minutes or so to present on things that you've seen so far or what your expertise kind of brings to the table also that we can add in what we get out of this 2 days of meetings. So if you didn't understand that from the email yesterday, it doesn't have to be anything formal. If you don't want to present, you're certainly not going to be forced to present, but if you want to for 5 minutes, we're going to kind of just go around the room, let you add any pearls or any words of wisdom to what we're kind of learning and putting together here that you think can be helpful. And we're going to do that for just the committee members and not the legislators, because we have plenty of time to listen to ourselves talk, and but anyway, if you have any questions about that, let me know. So to open today, we'll jump right into our first speaker if Ms. Cole is here. thank you for joining us today. And if you would, on the podium there should be a little button that says push that on the microphone there, and it should light up green. That'll let you know you have the mic. And what we've been doing is, in lieu of somebody introducing you, we'll let you just give a little quick brief introduction of yourself. Tell us what you do. Everybody who is presenting today and tomorrow has a desire to be a presenter. So there's no one here against their will presenting. So I think they all can add something, which may not be the case tomorrow in the roundtable. But I think they can all add something to our discussion that they feel can be helpful in what we try to get out of this task force. So Ms. Cole, if you would do that, and then we'll let you speak. And then if we have time, open up for a few questions.
Very good. Good afternoon. I'm Phaedra Cole. I am the Executive Director for Region 6 Communal Health Center. I've been with the agency for 30 years, LPC by trade, and I also serve as the current president of the Mississippi Association for CMHCs. Mr. Chairman, thank you again for the opportunity to speak with you all today on such an important topic. In 2023, the U.S. Surgeon General described youth mental health as the defining public mental health crisis of our time. Our kids are hurting in record numbers. Our schools are having to function as de facto mental health providers. So it's vitally important that we figure out ways that we can equip and fortify our schools to handle this crisis. But make no mistake, no single agency is going to be able to tackle this alone, not CMHCs, DMH, CPS, UMMC. It is going to take all of us working in a concerted fashion. With this in mind, my goals this afternoon are twofold. One, to give an overview of the CMHCs and how we're currently assisting the schools. And secondly, to give you all a roadmap of sorts on how we can address this problem from a holistic approach. So a quick overview of the CMHCs. We are the backbone of the public mental health system. We've been providing services for over 50 years. We were created by state statute, but we are governed locally. While we are certified and partially funded by the Department of Health, we are not DMH employees. We serve about 100,000 individuals a year, and I would estimate about 40,000 of whom are children. We shoulder about $30 million in uncompensated care each year and employ about 4,300 staff. The state was originally divided into 15 CMHCs, but if you'll look at this map before you closely, you will see there are some missing numbers. We are down to 11 CMHCs, so there's been a loss of 27% of the CMHCs. There's no more Region 1, 5, 11, or 13. Why is that? In a nutshell, we've been facing some of the same financial struggles as rural hospitals. Consolidation has sort of put a Band-Aid on it, but it's essentially sort of kicked the proverbial can down the road. But we want to make sure that we are still around for the next 50 years to support the schools, in which we have been doing for many decades now. The CMHCs provide services to public schools at no cost to the schools or to the students and their families. Superintendent Evans the other week made an important distinction between the role of his school counselors hired by the districts and the school therapists placed in the schools by the CMHCs. As he noted, his school counselors are primarily doing more traditional guidance and counseling activities. They're not doing therapeutic interventions. That is what we are there for. We are diagnosing and treating mental health issues. Currently in the schools, we are serving probably about 840 schools. I don't know if this reconciles exactly with how the Department of Education counts schools. If we're serving a junior high and an elementary on the same campus, I think that may have gotten counted as 2 schools. Roughly 315 school-based therapists, give or take, and we are dealing with a workforce shortage. I know that's been mentioned throughout some of the presentations. We have around 100 vacancies. The partnership between the schools and the CMHCs was strengthened very much by the Mississippi School Safety Act. That was a very cornerstone piece of legislation. I think, and from that act, there was an MOU that was crafted with the help of the Department of Mental Health and the Department of Education. I think that was sent out to you all this morning. the School Safety Act directed Department of Education, DMH again, to standardize an MOU that did 4 key things. One, it requires the CMHCs to offer mental health services to every school district. And the key word there is offer. The schools are not mandated to accept the services, but we are statutorily required to offer them. It standardizes the screening and referral process. And let me make this point as well. We are only screening those children that are referred to us. It's not a universal screening, and I think that's key for you all to understand. It requires the schools train all the staff on recognizing mental health issues and in suicide prevention. That has to happen at least every 2 years. I know Representative Creekmore was, making sure that that includes the bus drivers, the cafeteria workers, everybody. Everybody's got to be trained on those issues. It also required the Department of Education to establish 3 pilot sites in at least 6 school districts to implement an evidence-based curriculum to teach children in K through 5 how to manage stress and anxiety. So that's been a wonderful thing, and I know it's been in some of the schools in our area. The CMHCs, again, our school-based therapists are on-site in the schools providing screening and assessment, diagnostics, treatment planning, individual and group therapy, crisis counseling, and that may not be only with the child. If there is some sort of tragedy within that school, maybe a sudden death of a student or whatnot, we will provide crisis counseling to the whole student body. Day treatment services, basic consultation services to school staff. Some of the CMHCs are also providing CSS or community support services and nursing services. We also provide additional services off-site, either in the clinic or in the home. It's important to note that that student, if we're seeing them, is ultimately a client of the CMHC. So there's actually a whole army of staff and resources behind that school-based therapist. The child and family will benefit from that entire continuum, not just those services that we are offering within the school. Psychiatric services, psychiatric nursing services, family therapy. Typically, that school-based therapist that's in the school working with that child is also going to the home and working with the family in the home. CSS, again, wraparound, MAP teams, mobile crisis services, our 24/7-hour hotline, and targeted case management. So the advantages of embedding the CMHC therapist in the schools: reduces stigma and increases access to services. We're meeting that child where they are. The child doesn't have to be pulled out of school to come to their appointments and miss more academic time. It eliminates transportation issues for parents. Transportation is a real barrier for working parents. And also for the working parents too, they may have to take off work. They may be at risk of losing their job if, getting their child to their appointment. So it helps with that barrier as well. And again, it's provided at no cost to the school or family. And the referrals are less likely to fall through the cracks. The teachers or the principals are referring that kid, that the school-based therapist is on site, so that referral is less likely to fall through the cracks. The school-based therapist also is functioning as a part of the school team, giving much needed support to the teachers and administrators. Again, we're on site to immediately respond to a crisis, try to come up with alternative solutions to detentions, out-of-school suspensions. We're serving as a liaison between the child and the family and the school staff. And there's consistency with our services. I think that's key to know as well. Our services are not limited to the school hours. They're available after school, weekends, nights, during school holidays, summer breaks. So there's that consistency in those services, and that school-based therapist is still working with that child. So some current challenges, again, not every school, most schools are taking advantage of our services, but not all. Finding adequate space. I think Superintendent Evans mentioned this as well, actually finding a space in the school, because they don't, it's just not a luxury that they have. Workforce challenges. I know several speakers mentioned this as well. It is a huge issue for us. Most of our school therapists are trying to cover more than one school. And no universal screening of the student body. I worry about those quiet and withdrawn children that are not acting out, having fights in the hallway, they're getting overlooked. And since we're not screening all of them, I worry that those children are not getting the services that they need. Some considerations for strengthening the MOU from the School Safety Act. Again, it's a fantastic MOU. I think there's a couple ways that we can maybe strengthen it, and that would be to require every school district to accept services and not let that be an option. Again, trying to give priority to adequate space for our therapists, universal mental health screenings, and I'm going to say that a lot. You know, we need to have universal mental health screenings for all students, and expand those pilot projects that are working with the K-5 children on stress and anxiety management. And I think Superintendent Evans said that they are looking at trying to do just that. Okay, so a comprehensive approach. How can we build on a lot of good things that are already happening in Mississippi? There's the old adage that misery loves company, and there's a lot of misery in our company. Mississippi is certainly not the only state struggling with this issue. Every state in the union is struggling. The good news is Misery got together via the National Governors Association, which was chaired by New Jersey Governor Phil Murphy, who decided to make youth mental health crisis his top initiative. He held 4 convenings across the country, speaking to children and families, subject matter experts and state leaders, countless hours researching best practices and practical solutions, as well as what's working in other states. And that ultimately culminated in a document that Dr. Monroe sent out to you all this morning. It's called Strengthening Youth Mental Health, the Governor's Playbook. And it's pretty fantastic. So when you have time, please read it. I'm going to kind of go through pieces of it. But you'll notice once you open up the document, there's links embedded within the article that give you more detailed information that I'm able to do today. But the playbook is predicated on 4 pillars, so to speak. 1, prevention and building resilience. 2, increasing awareness and reducing stigma. 3, ensuring access to affordable and quality treatment. And I'll add timely, because if the treatment's not timely, it doesn't do much good. And 4th, training and supporting our caregivers and teachers. Pillar 1, and I'm going to spend a good bit of time on this because I really think this is the most important one. It is the foundation. Our ultimate goal, of course, is to reduce the demand for CMHC service. I was just telling Dr. Hogue a couple of weeks ago, I would love nothing more than for us to do some interventions that would put me out of business, right? We want to do it on the front end. And I'm sure Dr. Agnew would agree with that, right? Prevention is certainly better than a cure. Not only is it better, it saves money. $1 to $2 spent on prevention, you usually save about $7 in treatment. And prevention is standard in primary care, right? You got wellness screenings that are an inherent part of our healthcare system with checkups at certain intervals at birth, 3 months, 6 months. We immunize our kids. There's vaccinations at all but eradicated diseases like polio and measles. And we need to do that as a society. We need to immunize our kids for mental health disorders, and we are not doing that. Prevention activities are all but non-existent in mental health. And this is why we got a national crisis on our hands. I want you to sort of imagine this pot, as you see on the slide, that's about to boil over. And all we're doing right now is frantically sticking a spoon in it and we're stirring. It's all crisis oriented. What we need to do is to figure out how we're going to turn down that flame, right? Turn down the flame at the bottom. Prevention and building resilience is how we're going to turn down that flame. So we have to make mental health screenings as routine as vaccines and hearing exams and eye exams. Research will tell us that the first months of life, really from conception forward, play a critical role in the foundation of a healthy child to include their social, emotional development. So youth mental health, in my opinion, actually begins with good maternal health. We need mandatory screenings for all pregnant moms and at postpartum, presumptive eligibility, and extending postpartum care to 12 months was a huge step in the right direction. We know 1 in 4 maternal deaths are related to mental health issues. 1 in 4, and that's tragic. Babies born to addicted moms have chronic health care conditions, not only heart, kidney problems, but behavioral health problems, fetal alcohol syndrome, ADHD. And moms with serious mental health issues are at higher risk of preterm delivery and the host of problems that come with preterm birth. We also know, too, that maternal bonding is very important for a mom's mental health and the baby's mental health. Postpartum depression affects 1 in 7 women, yet half goes undiagnosed. Postpartum psychosis, while it's not as common, 50% of the cases are in women with no mental health history. The maternal bonding, so if they're dealing with depression or psychosis, some other serious mental health issue, they're not likely to bond with their baby. And we know that impacts the hardwiring of an infant's brain in areas that play a significant role in that child's lifelong mental well-being. So the second step, mandatory, first mandatory screening for moms and at postpartum, and then 2 mandatory social emotional screenings at pediatric visits, wellness visits, or whole health visits. There are several mental health screeners out there, some of that defined in your playbook for infants and toddlers. 43 states already use Medicaid to cover social emotional screening of a very young children. The CHAMPS program has been mentioned with some previous speakers. I think that would be a great program to expand and give access to the good folks at UMC, to those pediatricians who may be screening and identifying some problems. Mandatory mental health screening for all preschool age children. By the time the child is school age, there's a precipitous drop off of kids being taken to wellness visits, right? So that's where the schools can fill in the gap. But according to the Kaiser Family Foundation, just 1/3 of schools provide that service, universal mental health screenings. So, and it's also endorsed by the American Academy of Pediatrics. Universal screening too would also give an opportunity to assess the overall health of the school, look at the scores in the aggregate, maybe put more resources in those schools that have a higher portion of high-risk kids. Mandatory training of school staff. Things can deteriorate between screenings, right? So you need the school staff being able to recognize problems in between screening. And the good news is that through the Mississippi School Safety Act, this is already happening. Another consideration may be to require the teaching programs at local colleges and universities to incorporate mental health literacy as part of their standard curriculum for education majors. A little note of interest, North Dakota, and this may be something you all want to look into, but they have a program that utilizes an online role-playing simulation technology that helps school staff learn to recognize signs of distress in students and how to approach that student. Building resilience. Our youth need the necessary tools to deal with the normal ups and downs of life, right? Dr. Gleason, when she was here, discussed with you all the importance of adverse childhood experiences, or ACEs, emotional abuse, physical abuse, living at home with domestic violence, crime-ridden neighborhoods. We've got a lot of children that have to worry about gunfire on a daily basis. 60% of kids will experience at least one adverse childhood experience by 18. So the number of ACEs we know has a very strong correlation to mental health issues, cutting, suicide, drug use, acting out. So we need to figure out how we can make our kids more resilient. Again, Mississippi is already on the right path, and we just need to build on the successes, again, of the School Safety Act by expanding that social emotional curriculum pilot to all grade levels. So what's that return on investment, right? We know resilient healthy children are more likely to experience academic success, be gainfully employed, fewer interactions with the legal system, less likely to rely on social programs on the Medicaid system. Wyoming, their school programs are required to focus on reducing bullying. And they have to choose one metric like discipline, referrals, fights, and they have to track that metric to see how it changes over time, to see if their interventions are actually working. And again, this is discussed in more detail in that playbook. Maryland, I personally think this is fantastic. They mandate that each student participate in volunteer work as part of their graduation requirements. Engaged kids are healthier kids. NAMI, the National Alliance of Mentally Ill, also promotes that. It helps the kid build connections. It reduces loneliness. It gives them a purpose. It builds future leaders, and it's free. Pillar 2, increasing awareness and reducing stigma. Today's youth are much more open about talking about mental health challenges. It was one of the silver linings of COVID. Many celebrities, Lady Gaga, sports star Simone Biles, have come out about their own personal struggles with mental health and reducing the stigma. But the best recruits that we can have with regard to increasing awareness and reducing stigma are the students themselves. Any campaign to do so must include the youth. The kids have so much more influence over the peers than the adults, so let's elevate their voice, engage them in policy development. They need a real seat at the table. New Mexico, Vermont, Maryland, Kansas are just a few examples of states that have state youth councils that advise the governor and their state assemblies or their state boards of mental health. Personally, I would recommend doing this on the local level, having peer councils, much like student councils that can act as liaisons between the school officials and the student body. Some schools actually use specifically trained student peers as an integral part of conflict resolution and disciplinary actions, and which is ultimately much more effective than discipline that's just doled out by administrators and other adults. Some other ideas: peer drop-in centers at high schools and college campuses. Peers can integrate mental health awareness into their school clubs and organizations, recruit cheerleaders to have mental health pep rallies. Football players can lead ribbon campaigns. The 988 number needs to be on all student badges. I think this is happening at the colleges and university, but that needs to be accessible to every student. I know there's some other good things going on. Dr. Damon at Canopy, I think they've launched a wellness app for students. Kids love technology, growing those sort of programs. DMH has launched a resource app, so we need to expand those resources as well. Also, some states actually mandate a mental health coordinator position at their Department of Education, that ultimately coordinates all of these activities with the various school districts. Alabama is one of those states, and maybe somebody y'all can reach out to get more information on that. Pillar 3, ensuring access and affordability of quality treatment and care. And again, I'm going to add timely, because if it's not timely, it's not very helpful. Some of the barriers right now with the current system, it's a bifurcated care system, right? You have mental health here and primary care here. While we talk about integration, there's still not a lot of that going on. Parity is an issue, longstanding disparate treatment, and how insurance companies cover behavioral health disorders versus primary care disorders. The workforce shortage, it is real. We do not have enough staff to meet the demand. Again, the system has been more crisis-oriented instead of prevention-oriented. Again, how are we going to turn down that flame? And the system right now, candidly, doesn't support quality outcomes or innovation or true care coordination and collaboration. All the ingredients that you ultimately need for a very robust and healthy mental health system or healthcare system. The good news, the federal government has recognized this. And they realize that the mental health system nationally has just been really an utter failure. So they've come up with a solution. It's called the Certified Community Behavioral Health Clinic, or CCBHC model. It is truly the most transformative movement in mental health that JFK issued the Community Mental Health Act of 1962. It's a new provider type under CMS. It's one of those very few things that has bipartisan support nationally. It started under President Obama. It was enhanced under Trump, and it was put on steroids with Biden, with a plan to ensure that all states ultimately adopt this model by 2032. It ultimately puts the CMHCs on par with FQHCs. You don't hear of FQHCs failing and having to shutter their doors like the CMHCs. So this will give us that financial stability, so we're around for another 50 years and can be a good resource to the schools. It standardizes services across 9 areas to include integrating true integration of primary care and behavioral health care. The linchpin of this model is care coordination and innovation. It improves the quality of care, and those clinics that get the certification, they are held accountable to national quality metrics as well as state level quality metrics. And if you can't meet it, then you lose your certification. So how can this model help with the youth mental health crisis? One, it'll help us build capacity by addressing the workforce shortages. We've got to have more clinicians. We need a bigger army. That we are grossly understaffed, but this model will allow me to hire staff at a competitive wage. Right now, our master's level clinicians are making the same or less than the teachers. It also would fund activities that improve the quality of care, those prevention activities that I've discussed. It also gives the funding to train our staff in those evidence-based practices that we know work, and will produce those quality outcomes that we're looking for. Again, care coordination is an integral part of this model. A significant driver of the youth mental health crisis is the complexity of the system. which is often insurmountable for families and they fall through the cracks, particularly when they're shifting from one level of acuity to another. This model requires care coordinators that do nothing but help people navigate the system and making sure that that it's seamless, it's integrated across agencies. They help families make appointments. They'll double check to see if those appointments were kept. They'll make sure records got where they needed to. What was the follow-up from that? Making sure it happens at the next agency. So that is key. It also funds consultation services and activities. Schools need more than just those direct services that we're providing to the children. They need in-classroom support, classroom observations, helping with IEPs, training school staff on behavior support plans. This model would give us the resources to do just that. It also funds collaboration with other agencies again. We could have dedicated staff or liaisons to youth courts, detention centers, CPS, foster homes, et cetera. It also funds community engagement outreach activities. No matter how much PR it seems we do, there's a lot of people still don't know that we exist and what we do. So it allows staff to go out and make sure that they're aware where we are. And it's got a proven track record. This has been around since 2017, and every state that has embarked on this model has stuck with it. There's no state that has done a U-turn. On average, each clinic is able to hire 22 new staff, primarily care coordinators, I just mentioned, therapists and peers. States are seeing a very significant drop in their inpatient and ER visits, an elimination of wait lists, improved outcomes such as even the A1C levels, cholesterol, because there's true collaborative care. Just for time's sake, I won't go through it, but you'll see some states and some of their statistics there. Texas, for example, is projecting to save $10 billion by 2030, and they've been doing this for quite some time. There has been some movement with this model in Mississippi. The Medical Care Advisory in 2022 actually endorsed the model. We had a CCBHC planning grant. Kate McMillan was part of that team, and we've been working hard, so we're trying to get this out there. Pillar 4, last pillar, training and supporting caregivers and educators. Caregivers know their children best, right? But they need support. Some other things going on in our neighboring states. Kentucky, they have a family-to-family health information resource center that offers mental health support by connecting with their peer liaisons. DC has a parent support program that includes a monthly online support group for parents, as well as a mental health hotline. I just found out last week that Mississippi Families as Allies has a warm line for parents, and I know it's staying very busy, and that's something we need to expand as well. Last thing I'm going to touch on, and Superintendent Evans mentioned this too, is burnout with our educators and our mental health professionals. The RAND Corporation has found that educators are twice as likely to experience symptoms of depression than the general population. Educators can't help their students if they're struggling with their own mental health. A couple of states are doing some innovative things. Hawaii has a free mental health app for their teachers and administrators that helps with anxiety and depression. It's a confidential app. It tracks mood, does a lot of great things. Illinois, they've added 2 mental health days as part of their sick leave for full-time staff. So this last slide that I think y'all will have, and I won't go over it for time's sake, but it's just sort of a recap of some of the highlights that I mentioned. I know I've covered a lot, but most of what I did cover is in that governor's playbook that you all have. Investing in our youth is an investment in our future. And I hope this has given you at least a good overview of the CMHCs, what we're doing now, and in ways that I think we can build on those strengths.
Thank you. Just a couple of questions. You mentioned the pilot in the 3 early grades. You know, in going through this, we found a lot of different pilots going on across the state. What have you found in those 3 particular pilot areas where you're working with the kids at an earlier age? Has that been, I know you've said it's successful, but how do you measure that it's successful, and where do you see that success?
That may be a question better answered by Superintendent Evans. I think I recall him saying that they were looking at that data and seeing which of those curriculums that they wanted to replicate. So that may be something that he can, because I don't actually have that data.
And then you mentioned the Oklahoma having a an online program that they were using. And for some of their, I don't know if that was for the screenings, but, you know, kind of tying back into like screening for kids. How do you screen children at the youngest of ages for mental health conditions? So I understand your tie back to, you know, include this with the primary care providers and make that happen. But what does that test look like, and how is it given, and how would that be part of your normal kind of wellness? And that may be something Dr. Edney
Yeah,
can
Dr. Eddie may be able to help with this.
comment on too.
There
But
actually, some of the assessments are listed in that playbook. I'm not familiar with them personally directly. It's not something that I have administered, but they do exist for very young children. And I think, again, that's where the CHAMPS program could be so vital. You've got, you know, some phenomenal staff at UMMC that where pediatricians now can call if they think it's a mental health issue. They're not quite sure what to do with it. And they can call the folks at UMC through the CHAMPS program, get some guidance. So I think, you know, if we expand those assessments to really young children, I think the CHAMPS program would be a great place for that to rest.
Representative Robert, my co-chair.
You mentioned, I'm sorry, you mentioned that some of the schools weren't using the program. Have you heard any of, I realize you don't represent them, but do you have any idea of why they're not taking advantage of this if there's no cost attached to it?
I can't answer that. But as I said, most schools are taking advantage. There are a handful that are not, and I think that the reasons are probably, you know, vary. Not having a space or whatnot, or maybe they have some other resource that we're not aware of. But it's a smaller group that are not taking advantage than those who are.
I also have how do you get paid? How is this system paid through? Is it through a Medicaid system, or is it through the feds having this money and a combination of money from the state? How does that work? And if it is that system, what has been the experience of if you have to deal with managed care through that system? I see that look. I already know the answer to that one.
So if the child has insurance, we will bill their insurance. If they do not, we see them. We treat any child regardless of their ability to pay. And I mentioned that $30 million of uncompensated care, and it is crushing us. But we are required to serve anyone regardless of their ability to pay. We do receive some grants through Departmental Health that will supplement that, but it doesn't shoulder all the costs. And that's one of the reasons you're seeing the mental health system sort of collapse.
Representative Creekmore.
Now, Mississippi is part of the CCBHC. Is that right?
Not yet. Mississippi did receive a $1 million planning grant last year. And Kate McMillan with Division of Medicaid and the folks at Department of Health and Region 6 and Region 14 were part of that. We applied to be a demonstration state, and unfortunately, we were not one of the 10 that were selected. But there's another round of planning grants. They do this on a 2-year cycle, Representative Creekmore, because their goal is every state to adopt this model by 2032.
Okay, but we did get the
So
money.
it's not rolled out statewide.
Okay.
There are some CMHCs that have a grant, but that's on a very small scale. To be effective, it's got to be rolled out through the state Medicaid program. And it can be done. The advantage to being selected as a demonstration state is they get an enhanced FMAP rate of 85%. Some states, Kansas is one of them, Texas is another, that did it through a state plan amendment. They didn't wait on being selected.
Okay, and the universal screening, you recommend that every year for every grade?
Yes.
And we currently would not have the manpower to do that, I assume.
It would be a challenge, yes. Their schools are understaffed too. It would be a challenge, but that's certainly the direction we need to head in.
And it sounds like we would need that for our teachers as well?
Yes. Yes, and yes, but they are burned out, and so are our staff too.
All right, and then did you mention a mental health app for teachers?
Yes,
Out.
that's what one of the states is doing. I forget, I have to go back in my slides, but all of that information is in, and Director Bailey probably has some contacts from these states. I do as well, that we could reach out and see specifically what they're doing and how they implement it.
And DMH just released the mental health app for Mississippi, so we could incorporate that
Yes.
into that possibly. Okay,
And
thank you.
Dr. Damon, I know is on this panel, he's got an app that they were piloting, I think in Madison County Schools, Linda.
Any idea on what the universal screening, what that would cost?
I do not, sorry, I don't, but we can try to look at that.
Okay, all right.
Thank you, Mr. Chairman. And Representative Creekmore, just remember, for every problem, there are solutions. And I think there are ways to look at funding for this, perhaps through waivers through CMS. And also remember, as y'all continue to work on closing the coverage gap, then that solves a lot of the problems we're talking about today. Because one of the great beneficiaries of having full access for Mississippians are the CMHCs. And Director Cole, you know how big a fan I am of CMHCs from my substance abuse work. And FQHCs are under our jurisdiction, and between FQHCs and CMHCs and county health departments, I don't know what we would do if they didn't exist, and partnerships with our free clinics and everything else. But I suggest we say amen and go home, because everything I heard today is dead on track. And I hope our legislative leadership will listen to this, because I heard a lot of solutions today. And a big one is universal screening. And we can find funding mechanisms for it, but what's happening now, we're not screening, we're evaluating. We're evaluating children that we're seeing behaviors. And with screening, we will go a long way towards stigma elimination, because what's happening now is we're evaluating children, that flags them. But if we're screening everybody, if everybody's going through mental health screening, then we normalize it. We have normalized screening for diabetes and hypertension. There's no stigma. We need to do the same thing with mental health, and however we choose to do it, working together. But I really want to endorse everything Director Cole has presented today, and thank y'all for what you do.
I think we have time for maybe just a couple more questions, and then we'll move on, just if they can be somewhat brief, if you don't mind.
I'll try my best. Hey, Dr. Emily Johnson. So I'm up in the north part of the state, and I very much appreciate all that Lifecore has done tremendously. But I want to highlight for the group, you were talking about that you have 90 positions you could for school-based therapists hire at this minute. One of the things that I see as well is our ability to recruit. And then, as you were saying, the retention is one of our biggest things. So, because it's getting the people that are able to do that. In your estimate, I know you don't have the number on this. How many of those school-based therapists that you get in do you feel like you retain for 5 years?
Oh, gosh,
Like percentage-wise?
maybe 40%.
That's what I'm thinking, if not. And so also the other thing we look at is when they're leaving community mental health, do they tend to leave Mississippi, or they're going into the private sector in Mississippi?
The private sector. Yes, and I could do a whole presentation on that very issue right there. So, yes, it's a big issue for us.
Thank you.
Yes. Last question. You got one more, and then you're off the clock.
Thank you. That was very good. And I have the pleasure of getting to work with your staff, and they do great work. And they are out there on the front lines in very difficult circumstances. One thing I've noticed is that a lot of the situations they come up against are specifically about education issues in special education. And I think we want to give them more information about that and support them that way. But I do think if your staff, not just your staff, but if mental health providers that are going into the school could do more consultation, more help in the classroom, I would, and you know how I feel, I don't know that there needs to be as much day treatment and all that. I think if we could do a lot more with the kind of people you have working with you and give them that support and find ways to change billing codes to support that kind of work, I think tremendous things would happen. And I think that would also open up some doors for universal screening, correct me if I'm wrong, through what's already in the schools through the tier process, building on that. There's already a lot there we could build on.
No, I agree. You know, as I was saying earlier, they need more than the direct service provision. The teachers need more support. We need to be in the classrooms observing and helping intervene in the classrooms. And the system's not designed that we can do that. The CCBHC model is designed and it would afford us the ability to do that. And the consultation, that is one of the things they look for. When you design your model at the state level, you have to be doing those consultations. Absolutely. Agreed.
Very good, thank you. So, one thing I get out of this is that, coming into a task force like this, you wonder where our state kind of ranks or stacks up against others. And we certainly have some things we are doing right, and we have some things that we certainly need to improve. But in every presentation, I hear that we have not just been ignoring this problem. We've been trying to move towards solutions. So with that in mind, in kind of putting together speakers, there was some feedback that we wanted to make sure that we had school counselors and representatives of the School Council Association are here with us today from the Magnolia State School Counselor Association. We have co-presenters, and it's Crystal Brewer and Dr. Ebony McGee Dorsey is the assistant chair, and we've got basically 30 minutes kind of set aside for you here. So hopefully you've coordinated a little bit and you can use that time. We'll have each of you just kind of present individually, and then at the end, we'll open it up for a few questions instead of breaking it one by one. So again, just give us a little background on yourself and just go into how you think you can help us and what we're looking at here.
Okay, we are so happy to do that. And we just want to thank you for allowing us to be here today. My name is Crystal Brewer. I am a school counselor. I am just beginning my 24th year as the school counselor of Simpson Central School, which is in Pinola, Mississippi. Anybody's ever been through there, you had to be going there because you don't really go through there unless you're going there on purpose. But it has been my joy and privilege to serve those students, that community for all of these years. I currently serve as the chair of the Magnolia State School Counselor Association. We're a relatively new organization in our state, servicing school counselors because Dr. Dorsey and I believe very strongly in the role of the school counselor. So we are thrilled to be here. I'm gonna let her introduce herself.
Good afternoon. I'm Dr. Ebony McGee Dorsey. I am the CTE counselor and district school counselor for the Lawrence County School District. I'm the assistant chair for Magnolia State School Counseling Association. And one thing that Crystal failed to mention is I'm currently on the board for our American School Counselor Association. And Crystal is a former board member. So we're also bringing perspectives from a national outlook as well. But I'll let Crystal take back over.
All right, so we're gonna just kind of, we provided some handouts and we're gonna talk about that. But honestly, as school counselors, we're gonna talk to you a lot today from our heart because that's the work of school counselors. And we're so excited to be able to share. And honestly, the information that Ms. Cole shared, I feel like we're gonna speak in tandem to so much of that because so much of what I heard her say we need, guess what? We have the answer. It's school counselors. So we're just excited to be here and to present today. So the first thing we're going to talk about is the role of the school counselor. And I think it's so important that we talk about this because if you are like me, when you were in your K-12 experience, may have had little to no interaction with your school counselor. I don't think I did until I got ready to be told what my rank was. And, like maybe, hey, have you registered for the ACT? That's what I knew of my school counselor. I was sharing with Ms. Cole, it's the reason why I didn't consider school counseling when I was going into a mental health field because I wanted to help children. And it wasn't until I went and did an internship that I thought, man, this is what school counselors do. This is not what I thought that school counselors did. The role of the school counselor has shifted tremendously since I was in school, and I would venture to say since most of you are in school. And so many of the things Ms. Cole was saying that we need in schools, that's what we're there to do. So we have provided a handout for you. You can look at there that just talks about what specifically the role of the school counselor is. We are there to be proactive, deliver a comprehensive program that is developmentally appropriate for all students. Every student in the building should be impacted by the work of the school counselor. We are there to service students in 3 domains: their academic development, their social and emotional development, and their college and career readiness. Obviously, today we're talking about how we fit into that social and emotional realm. But I think it's also important to note that in Mississippi, the current school counselor to student ratio is 1 to 389. So when we talk about the ability to really service students in all of those areas, it is a challenge. And much like in community mental health, we are also struggling with having enough school counselors. So we know that we don't have as many people going into the profession. And we also have a lot of people who are leaving the profession because many of your school counselors are also licensed professional counselors. They can go into private practice. They can take those skills and work in another area. If you look at the second page of that handout, it also shows you the coursework that school counselors have as part of our preparation program. And you will see there that our preparation program and LPC preparation programs go hand in hand. We take almost exactly the same coursework. So we are trained in individual counseling, in group counseling, in crisis response, in multicultural counseling, in all these areas that we can support students. So it is part of our job in this role. We really want to advocate and help educate about how the role of the school counselor is different than what it was when I was in school, or maybe when you were in school, because school counselors are a vital part of the educational system. Anything? Okay. I'm going to be the speaker. So one of the things that I think is also important, and Ms. Cole talked about this a lot too, is resiliency, right? So we included for you the student standards for school counselors. Now, you may not have known that school counselors had standards that we are tasked with ensuring that students are being successful at, but we do. We have mindsets and behaviors. And if you read through those, you'll begin to see that resiliency is one of the things we're supposed to be working on. Sorry, my mouth is dry. So we have specific things that we are tasked with helping students. And we can do that in preventative ways. School counselors ideally should be pushing into classrooms and teaching lessons to students beginning in pre-K on things like resiliency and coping skills and safety things. Like, we should be pushing into classrooms and doing those lessons, teaching on social and emotional skills and helping students develop those things, because sometimes we're helping students break a cycle, right? Sometimes we have students who are coming in who are living in a home that is plagued with mental illness or addiction. And so we're having to try and help these students learn and develop skills to live a more healthy, different way than maybe what they know. So that is one of the tasks that as school counselors we should be doing. We should be pushing into classrooms. We should be doing individual counseling and group counseling and organizing whole school-wide initiatives around these things. And frankly, under our Ask a National Model framework, that is what we are tasked with doing. So the role of the school counselor, I hope, is a lot more than you maybe realized that it was. So challenges, and I think we're going to talk hand in hand there as well, Ms. Gold. So challenges for school counselors to be able to do these things that we are tasked with doing and that we want to do. Staffing is a problem. Ratios, student to school counselor ratio It's a problem. School counselors are not mandated. And so there are students in schools that do not have the benefit of a school counselor that is providing these services for them. There is still lots of confusion among our people in leadership about what the school counselor is supposed to be doing. And so if our principals don't understand that we are not those old school guidance counselors, then they are assigning us tasks that are very much just focused on record keeping and clerical tasks and organizing and, and those things are not without value. But when we're in the middle of a mental health crisis, is it not so much better for us to be utilizing the trained mental health professionals in the school building to actually be meeting the needs of students and helping to be preventative? We too spend so much time just putting out fires. But if we had our time protected and there was better understanding of what we're actually there to do, then we could hopefully be more preventative and prevent some of those fires from even being lit in the first place. So that is an ongoing problem. Because this has continued to be a problem, there are lots of people who are just choosing not to go into the profession. The University of Southern Mississippi just graduated its last cohort of school counselors. They have shut down their program for school counseling. In speaking to other graduate level programs in school counseling across our state, they struggle to get people to want to be in the program. And then once people are in the program and have gone through all of this training to be a school counselor, they go to an internship and they see all the things that the school counselors are actually doing that's not working with the students, and they'll switch over to the other track. And so that is an issue for school counselors to really be able to meet the needs of students. Anything else you want to add to that? Okay. All right. So solutions, we're just, we know, and we understand, because we've worked in education long enough. We understand it always comes down to there's not money to do these. We understand that. We understand that our legislators are in that situation of trying to figure out, how do we do these things? We may want to do them and we know that they're what's good for kids, but how do we do those things? We really feel strongly that school counselors should be mandated. And while we are so appreciative of community mental health, it is such a blessing for me. We have Region 8 in our area, and we do have school-based therapists who come in when we identify a need with a student and we refer them. Those Region 8 therapists come into the school. And for some of us, especially in rural areas of our states, parents are not going to take their children to the mental health center. So if those therapists were not coming into our schools, those children would not be getting that service. So it is invaluable, but it doesn't take the place of a school counselor who is embedded in that school, who knows those students day in and day out. For me, if you hang around 20 plus years, you get the joy of watching your former students bring their children in and enroll them in kindergarten. And you get to talk to their little kids about how, I remember your daddy when he was in first grade. And so, we get to invest in those communities, and we don't just know our students. We know the families, we know the community structures that are at work in our communities, and they are vast and they are diverse across our state. It's not going to be a one size fits all, but a well-trained, well-equipped, supported school counselor is invaluable. And so we need help spreading this message that school counselors are not the guidance counselors of old. And we are certainly doing everything we can, and Magnolia State is going to do everything we can to spread that message up. But anytime you're going from the bottom and you're trying to push that message up, it's pushing a boulder up a hill. So what we need is people in our Department of Ed and people in our legislature who are pushing that message down for us and sharing with our district level and our school level administrators. We need you to be utilizing these school counselors for what they're trained to do. We need you to be mindful about what tasks are being assigned so that they can be in those classrooms, they can be working with students, so that we can see those impacts and so that we can identify when there are students who are in crisis and need to be referred to the community mental health. Because if we're sitting in our office working on cumulative folders for 6 hours, we don't know that there's a crisis. Or if we're the school test coordinator and we can't have anybody come into our room because it's cordoned off with state tests, that baby who's having a crisis, we may not be able to address that immediately. And that's really hard. So we would very much like to advocate for school counselors should be a must, and every student should have access to a school counselor. And we just need help really spreading the message that school counselors need to be used effectively in the overall collaborative work that we're going to do with community mental health, that we're going to do with families, so that we can identify and we can support our students from the very first day they enter school, all the way until the day they graduate from high school and they go off to be productive citizens in our state.
Just one thing I want to add, we mentioned universal screeners earlier. And as a school counselor who used to be on the elementary and middle school level, that is a wonderful tool that we would love to have. And I have advocated in my district for years, can we get this? And I'm always told, but we don't have the money. If we had those universal screeners as school counselors, we're able to dig a little deeper. We're able to find those students that we're usually missing, the quiet ones, the smart ones that slide on by that we are not recognizing if we had those universal screeners. So I did want to go back to that and say, as a school counselor, yes, because when we're working with our students in tier, all we're hearing is academic, academic, academic. We are not touching on the behavior aspect when it comes to tier. So thank you. I did want to say, I appreciate that. Thank you.
And I would just piggyback on that too and say that that is something we want to know. We want to identify students early. But if there's not the trained people from community mental health and there's not a school counselor in that building, what good does it do to identify children with needs if there's no supports available for them? So, you know, it can't be like a one-pronged solution that we're looking at. We have to look at like, how are we going to strengthen all of these pieces of the puzzle so that it all fits together and it's working effectively for our students? Because I do agree 100%, and that's not just a Mississippi thing, that it is a mental health crisis. When the second leading cause of death among school-age children is suicide, it's a crisis, and we should all be trying to figure out a solution. So, questions for us?
I've got a couple, and then Senator Bryan has a couple after me too, I believe, but so you do see your profession as being the profession that could implement or provide the universal screenings that were mentioned earlier? And you said that the ratio that exists right now is 389 to 1, and ideal would be 250 to 1.
That is the recommendation by the American School Counselor Association. If I'm being honest with you, I think anything that provides more support is always in the best interest. I wouldn't focus solely on like a magic number, because I don't think that exists.
Right.
But I just think more is always better.
So we would have to move towards that ratio, and that doesn't seem like, 1,000 to 1 would be more challenging than going from 389 to 250. But one thing we've done in other avenues, we've looked at when we added career coaches, we've kind of been doing over time a little bit of a phase in there, where we started at one level and we've added some over time. Because you've said that with USM stopping their program and there being a smaller pipeline coming in, even if we decided that, hey, we wanted to fund more of this, I don't think we have the people out there who could fill that role. So do you think it would be beneficial to look at kind of a stepwise type of program to try to get there? And and how, if you have any ideas, could that be done? Because I don't think even if we decided to do this, that we could do it all at once.
Okay. I would say I completely agree with that. I think that there has to be some intentional work around kind of what we talked about, the recognition of the role, so that people who are going into the profession are actually getting to do the job to help students that they went to school to do and got all the training to do. And that's not gonna, like, you're not gonna flip a
We
switch.
would take some of that. So how would you propose the way to do that would be? Would that just be your profession interacting more with the schools? Would that be that the legislature, put more, not mandates or more targeted roles upon your profession that would maybe force the school system to decrease maybe the admin burden that you may be doing as a side? What do you think, our way of creating that could be, if that was a direction we were considering?
I don't think there's going to be a one-size-fits-all solution, just because I think there are some districts that have more resources, that, there are more people available to do all the things that are being asked. There are other districts like in Simpson County or Lawrence County where we are part of fair share responsibilities, but there are some duties that I think it would really help if school counselors could have shifted off of them. And I don't know if that necessarily goes into, something that is a law, but it goes into kind of like the way we inform and encourage our people who are in leadership. I know principals and assistants, they're doing the best they can. I realize that. So it is difficult because everybody's kind of struggling right now. But I just know if our focus is on helping students' mental health, then we've got to prioritize school counselors and the work that they're needing to be doing, not the clerical work. And I don't think Ebony or I, either one, would stand up here and say, we don't want any of the, we can, and we can do those jobs effectively. I think most school counselors can do those jobs effectively, but is that the best use of our time and our resources? So how exactly that happens, I think that would be something that the legislators or the Department of Ed would have to kind of figure out, like how we encourage that to be the case. But I think we need to be moving in that direction.
Okay. Anything from Co-Chair? And then Senator Bryan right after that.
You kind of centered on something whenever you were talking. One of the things that I've heard from counselors, and especially whenever we were getting deeper into the mental health side, it's going to do us no good to put additional counselors into a position in which we're allowing other jobs supersede that. Either we're going to have to decide that this is an important function of our school system that is separate and different than what has been done. And one of my frustrations, though, and I'll just be honest with you, I'm not an education professional. Why is it that we're having to come up with solutions for what is obviously a problem in our schools where we have mental health issues and we've got counselors that are already there and we're up here having this conversation? That's frustrating to me.
One thing that I will say, and I've been saying for years, and I hate to say this, but as school counselors, sometimes we feel like we're highly paid secretaries, that we're not trained. I'm not trying to be funny, but anybody can go and do a CUNY. But the work that we do, that we're trained to do, our master's level programs trained us, it wasn't on CUNYs. It wasn't on the clerical work. It wasn't on registering kids. And while we have to have those things to maintain the school, is it helping our crisis?
Senator Bryan.
Well, first of all, I'd just like to remind all the people making presentations that we have this very expensive state-of-the-art sound system in here. And it's very, very sensitive. And if you don't speak right into the microphone, we simply can't hear what you're saying. Now, we used to have this old antiquated system that everybody could hear with, but we got rid of that. And we've got this really expensive state-of-the-art system. So now you have to speak right into because seriously, it's just difficult to hear what you're saying. But there was a reference to money somewhere in there. And of course, you know that we're in the process of a $1 billion tax cut that's being phased in. That's $1 billion a year, every year, in perpetuity, indexed for inflation, gone from the general fund. And there is this relentless attempt to abolish, listen to me, abolish the state income tax, which would be like, another third of the general fund, 3 billion, whatever it is, a year, forever, gone, gone, gone. So every time I hear this comment about the legislature not having money or we're short of money, trust me, I've been here when we're broke. We ain't broke, but we're getting ready to make ourselves broke, which is a feature, not a bug. We're getting ready to make ourselves broke if we don't stop this nonsense. And the fact that we have inadequate services for mental health, children going uneducated, sick people going untreated, water and sewer systems not being maintained, and highways not being built is because of intentional policy decisions made by your state government. And my question is, aren't you glad you got that little nugget?
Yes, thank you very much.
Representative Creekmore, and then we'll try to hit the legislators first.
Yeah, thank you. As a school counselor, just for high school, or do you recommend them in elementary and junior high?
Everywhere there's a student, there should be a school counselor.
Okay. And in your scenario with a counselor in every school, how often would you meet with a student?
So it's based on what that student needs, but ideally, the school counselor should be having a comprehensive program. So they're going into classrooms and they're servicing every student through like classroom lessons, whole group activities that may be happening with the whole school. When they identify students who need additional support, they do that through individual counseling or through group counseling, depending on what the situation may be. And then, school counselors are not set up to be long-term therapists. But if we identify that the student has a need beyond what we can meet, that's when we would refer out to community mental health.
So it is one-on-one and group meetings.
Yes, sir.
And you referenced that y'all are qualified to do the screening just as the CMHCs do.
So we did a screening last year in Simpson County, and it was a teacher-reported screening. So the teachers basically rated on the screening. The issue that we encountered was we identified all these children, but then we didn't have the services and the people to actually implement the interventions that would be warranted from identifying them. And I mean, again, it goes back to, even if we were to refer 150 kids to the community mental health agency, they're not equipped to service all of those students that would be identified.
Okay. And then it sounds like y'all would like the Department of Education or the legislature to issue guidelines as to what your job requires and stick to that.
We would love that. And I will just give you, kind of going back to what Representative Robertson asked earlier. I haven't seen a school counselor contract that we signed that the last line item after listing the things school counselors should be doing is, and other duties assigned by the principal. And those are, in some cases, a majority of things, and they go back to, non-student focused duties.
Gotcha. Thank you.
So just leading off of that, just briefly here, in our last meeting, I believe it was Dr. Baker brought up when we were talking about suicide prevention in particular, we got into the concept of, you've mentioned the one-on-one kind of a situation, but we talk more about kind of assemblies or larger gatherings with students there, maybe between an entire grade, where there's more education on that in a larger group instead of the one-on-one. And we gave some thought in this group as to who would be the person who would do that. And I guess at that time, my thought was that we would maybe find someone who would rotate around the state who would fill that role. But are you saying that the counselor should be doing that role in the schools? If we had a counselor, should the counselor be leading these assemblies and be providing, through the education the counselor always has, is there already an advocate in the school who can be doing that if we made that a requirement for the schools?
I think that it takes both, to be honest. And so let me take this back a little bit for a minute. If we mandated school counselors and we had them starting, especially elementary level, we can be more proactive as counselors. Most of the time, we're gonna make sure that we have a high school counselor because we wanna make sure that these students graduate. However, if we have them in the elementary, we're able to go in and do those classroom lessons. We don't have to wait till they get to high school to do those assemblies. We could start pre-K, kindergarten, first grade, incorporating those lessons if we have school counselors there. However, yes, there are things that happen. My district was one where we did have to bring in outside resources and community help because of a tragic event that we did have. So I think it takes both. I think it takes us collaborating. Let me say that again, collaborating. That's something I don't think that has been happening. I think everybody has been very protective of their role. And I would love to see us collaborate more.
I will say that I do think school counselors are qualified to provide trainings. I train our staff every year on signs, protective factors around suicide. We train every year on what they should do as teachers, as bus drivers, as cafeteria workers, if a student in any way indicates self-harm. And there are protocols around how we address that. And, depending on the severity of that threat, we do bring in community mental health oftentimes for next steps, for protective measures to be put in place. But school counselors are actively involved in suicide prevention every day in schools. And if I'm being honest with you, we probably do threat assessments on students quite routinely across the state.
In the last hearing, it was brought up that school counselors would need mental health first aid training, but it doesn't sound like that's necessary. Y'all are already trained in it.
Yes, we are trained.
So, okay, we can take that off the table then.
We do have training, but if I'm just being completely transparent with you, I think that, I tell people all the time that when I think I know everything in public education, it's time for me to go to the house. When I think I am done learning, I need to leave this profession. So I think that school counselors can always benefit from having ongoing training on mental health first aid, on all the factors that we help students with, because we don't know everything. And we're just like anybody else in any profession. We all have our strengths and our weaknesses. And so we always need to be honing our skills so that we can serve our students better.
You've been very patient. I'm sorry.
Hey, good afternoon.
Hi.
How are you?
Good.
I'm Wendy Clemens from the MDE. It's good to see you. I am a huge proponent of school counselors. I've been a K-12 building administrator and have given a choice between an assistant principal and a counselor. I would pick a counselor all day, every day. So I do appreciate y'all's work. We do, in fact, have policy 2.4 that does talk about the 80-20 split with ASCA. Which is 80% of time that is direct services to student. And then the other 20% is really supposed to be your paperwork that allows you then to serve your students. And what oftentimes happens is it's interpreted as other paperwork. So I do think needs some clarification there. But my question is, say, for example, in the next 3 to 5 years, we are able to get, say, to a ratio of 250-1. Let's just use that ratio. I have put the numbers to that to figure out what that would look like, but we do not have the workforce. I mean, we can require it. We just don't have it. what is your idea? What should we be doing in our state? Because it's like, which came first, the chicken or the egg? You know what I'm saying? How do we get more professionals to get into counseling? Because I don't disagree with you. I think it's great. But we've got to have a plan to fill those positions if we in fact get to that utopia that we want to be.
I think it would have to be a multifaceted approach. I do think that doing the intentional work around the role of the school counselor and helping administrators and people in leadership kind of understand that would encourage more people who really have a heart for this work. There are a lot of people who may be currently teachers or in other professions in the school who are looking and saying, I'd really like to be a school counselor, but sometimes they get discouraged and they don't go into that. I also think we need to work in collaboration with our universities and colleges to ensure that we are turning out, people who are, well-equipped and that we're kind of giving them an accurate view of the task at hand. But I think that those things are going to have to kind of happen in tandem for anything to really change long-term. And I do 100% recognize and agree that, the capacity is not there right now. But I think if we don't do the work around intentionally safeguarding the role of the school counselor, we're never gonna build to that capacity. And our kids are continuing to kind of be the ones who are suffering because we don't have those supports in place. And back to your 80-20, I do appreciate that. And that is true. I think the thing that I would say is that it doesn't get checked in any way or form or so. Like it is in law, but there's no vehicle by which anybody is being held accountable. And so like if my principal says to me, you're going to spend the next, 6 weeks working on CUME folders, I have to do whatever my principal tells me to do. And that's kind of the area that we find ourselves in sometimes. But I do appreciate that bill. And I appreciate that that was, put into place because I think that that is best practice. I just think, how do we move to that being the reality for our students and our schools?
We'll do one more question. We're trying to be right on time, and that, to that point, that's why we put the career coaches actually outside of MDE, was because of the reporting and accountability being kind of an issue right there. And so we've got a different mechanism that we've done on the career coaches that MDE certainly at first had some reservations about, but has found, I think, a way that's been beneficial. So that's a good comment that you bring up through there. So one more question, then we're going to move to our next presenters.
Thank you. This may just be a clarifying question, and NDE can explain it to me, but what is the difference between a master's level counselor who has gone to school to be a therapist and is independently licensed versus the school counselors who are either bachelor's or master's level teachers and they're certified teachers?
So you can't be a school counselor in the state of Mississippi without a master's degree. So all of us have master's degrees. Most of us have the coursework. Ebony is an LPC. I have all of the coursework that I need to do that. I've passed the national counseling exam, which is what you have to be a board certified school counselor. I'm board certified, Ebony's board certified. The only thing I haven't had that would allow me to be an LPC is supervision hours. So that's from my vantage point. And if, there's a different answer, but I mean, that's all it would take was me basically paying somebody to supervise me for 100 hours and submitting all my paperwork.
Okay, very good. And I hate to cut this off because we're already a couple of minutes short, but I think your perspective, following mental health is very good. And that's what we're trying to get here, is everyone's perspective so that we can, figure out some good recommendations made. So we thank you today. We're going to move on to our next presenters here. We've got co-presenters again. I think that worked good. So I think that it'll work good again here. So I'll try to speak in the microphone a little bit more. So Again, I'm gonna let you introduce yourself, but we got Dr. Hannah Allen and we have Dr. Erica Montgomery, both from the University of Mississippi. And again, these are presenters who, felt that they had some information that could be helpful to us. And so we look forward to hearing what you have to say. So I'll turn it over to you.
All right, great. I'm going to make sure I know how to do that. All right, if we're not loud enough, just give us I'm like worried now. Just give us a hand. So my name is Dr. Hannah Allen. I'm the executive director of the William McGee Institute at the University of Mississippi. I actually started that job on Monday. So this is my first official presentation, but I've been a public health professor at the University of Mississippi since 2020, which was a wonderful time to start as a public health professor.
I'm very thankful for the microphone today. This started last night, but I'm Dr. Erica Montgomery, and I am the clinic director of the COPE Counselor Education Training Clinic at the university. I also adjunct with the Counselor Education Department, and I'm our program coordinator for practicum and internship experiences. So I've been at LPC in the state for about 15 years, and just happy to be here. Thank y'all so much.
Oh, no. Is this the clicker?
How do we?
Oh, there we go. So we wanted to present together because we feel that we sort of represent the spectrum that's needed to be able to focus on this issue. So I'm going to focus a little bit more on the public health and the policy sides of things. And then Dr. Montgomery is going to talk more about sort of the treatment and practice part of that spectrum. But we just want to acknowledge and thank the task force for having us here today and also recognize the University of Mississippi as well. So just to talk a little bit about where we're from. So once again, I'm the executive director of the William McGee Institute. Many of you might be familiar with William's story. William McGee was a University of Mississippi student who died from a drug overdose in 2013. And his family has been very active in making sure that his legacy and the legacy of other university students and youth that have died from substance use issues, that has not been in vain. So the William McGee Institute operates in his name, and our mission is to develop innovative, collaborative, and transparent research to improve overall student well-being, but we do focus mostly on mental health and substance use issues, but we look at the student as a whole. And so we have two main centers, so I oversee both of those. We have the William McGee Center for AOD and Wellness Education. That focuses more on, that's our programming arm, so they do more of our external health education work. And then we have the Triplet Center for AOD Research, which is our research arm. So that's more of our grant funding, where we do most of our more like analytical and scientific research. And the reason why we have both of those is because that has to be a partnership. So we want to research these issues, but then we want to take that additional step, because oftentimes in academia, we get caught in academia and the information doesn't leave academia. So our job is to take what we've learned and then to translate that and take it to you, policymakers, take it to counselors, take it to teachers, and say, this is what needs to be done, this is what we know. So our job is to scale up the research that we're finding and to be able to support students and their families from K to 12, and then also in our colleges and universities.
So counselor education is our counseling department. That's where we do mental health counseling and school counseling tracks. And we focus on the clinical mental health training aspect at COPE. COPE offers free mental health services across the state. As long as the person lives in the state of Mississippi, they can receive free counseling services, either via telehealth or in person at our clinic in Oxford. So the way that we're able to do that for free is our services are provided by interns in our master's program. They're supervised by doctoral level students and by clinical staff. So we are externally and grant funded. We're not funded by the university. So that means that I have to hustle for our money. I have to go out and talk to people about partnerships and how we can serve them and what that might look like as a collaborative engagement. So some of our partnerships include UMMC. We do have an assistant clinic director who's funded half part-time with us and part-time with their Telemental Health Center for Excellence. The Kellogg Foundation is one of our biggest partnerships right now, and we are servicing their partners, the Jackson Revival Center here in Jackson. It's an after-school program where we are helping children with their social emotional learning skills and then conflict resolution and communication skills, because they're from heavy gang oriented area of Jackson. And so we're trying to be proactive instead of reactive. And we're trying to teach them the skills that they need to be able to manage their conflicts before they get to a place where they feel they have to choose that direction in life. Also with the Kellogg Foundation, we're working with program Believe in Biloxi, which is misplaced immigrant families who were been trafficked here. And so we are offering individual and group services to them as well for free. Recently, we are working with the Office of National Drug Control Policy, ONDCP, and Baylor on a grant that enables us to work with drug prevention in the schools. It was supposed to be wraparound services, but we are already placed in Oxford School District and Lafayette School District with our mental health counselors on campus, which really is a support to our school counselors and our CMHC counselors, just to be able to have an extra body there. We have an intern in every school in both districts, just so we can have filling in that gap in the caseloads. So one of the things that the ONDCP grant allowed us to do was to create programming for these kids who were having vaping issues. And what we found through that was that the issues were much deeper than just vaping. And they were vaping as a way to deal with not having their drug of choice during the day. And their drug of choice really was there to help them cope with the stresses of life. So we were able to create our CHAMPS program. Every time she talked about CHAMPS, I was like, well, we've got one of those. But our CHAMPS is choosing healthy alternatives, mentoring, and peer support. So it looks like we have staff and doctoral students in the school leading these groups, and they have a specific tailored curriculum for drug prevention. And then with these students, they begin to mentor, high schoolers are mentoring eighth graders are mentoring sixth graders, because we're seeing these issues start earlier and earlier. But then they're also working with their RISE program in Oxford School District for peer support. So we're trying to take an attack from all sides with this, just to be able to work on these drug prevention issues. We do understand that it is better to prevent than to be reactive, and that's what we're working on. Upcoming partnerships for us include Pike County Detention Center. We are creating right now a 6-week curriculum focused on restorative justice. Restorative justice looks at how their behaviors impacted their communities and what that restoration is going to look like when they go back into their communities, and how we want to move forward with healing. And then we also offer youth mental health first aid to K-12 teachers and administrators in our area and across the state if they're interested. We also have this in our secondary education classrooms when they enter their senior year before they go into their internship. I don't know what it's called for them, but before they go into what we would call our internship, we offer them youth mental health first aid so they are certified for 3 years in that before they leave our university. So the University of Mississippi really sees the need to come at this together in a collaborative way. One of the ways that we are addressing the lack of workforce, and we'll talk about workforce development in a few slides, but just having incentives to be a counselor. What are the incentives? How do we fund our interns so that they have fully funded graduate assistantships? Well, it's through partnerships like this. We get grant funded. We fund the people that are going out there and doing the work in these communities so that they have their school paid for. And that makes all the difference for them being able to do this hard work. Give it back to you.
All right, so I'm going to do a brief overview. This is already in the information you've been given, but just kind of set the tone before we get into some more clear recommendations for what we think the best practices are for this task force. So just to kind of ground us in the state of the issue is that mental health challenges are the leading cause of disability for young people today. And about half of the children that have a very treatable mental health disorder are not getting the treatment that they need. And we've kind of talked a lot about why that is. We have seen that this problem is getting worse in the past decade. So there's been about a 40% increase in mental health issues for high school students in the last decade. And we've also seen about a 60% increase in suicide rates among youth. And this is nationally in the last decade as well. There's a lot of reasons why this is happening and why it's been a bigger problem as of late. We see this linked to our growing use of digital and social media, increasing academic pressure for students, limited access to mental health care, which has been a point that's been made several times today, links to substance use, which I'm going to get into, and then broader stressors that we've seen more in our overall environment, such as the pandemic, income inequality, and then rising issues of racism and gun violence. So we need to really focus on our high-risk groups. So we've talked a lot and kind of used the word universal, and that certainly has its place when we think about screening. But when we think about good use of money, we want to make sure that we are not just throwing money broadly, but we're really going at the places where it's needed the most. So we need to have research that tells us who are those high-risk populations. So when we think about mental health challenges among youth, they're most common, and there is a gender difference. Among females, most commonly, they're at higher risk for anxiety, depression, eating disorders. Males are at higher risk for disorders like ADHD and then completed suicide. And then we also see that there are different demographic groups that are at high risk: racial and ethnic minority youth, sexual and gender minority youth, youth that are come from low-income families, and then youth that live in rural areas. Substance use operates a little bit differently when we think about our high-risk groups. It tends to be higher prevalence and worse outcomes among males, Black and African-American youth. This is actually a recent reversal. For decades, it was higher among white adolescents, but in the last decade, 10, 15 years, 20 years, we've actually seen a reversal here, and prevalence is generally higher among Black and African-American youth, and then also students without aspirations to attend a four-year college. So when we think about young adults, having that goal, that post-high school goal, is very important for substance use prevention. You're going to see me talk about mental health and substance use simultaneously, and that's on purpose because they are linked, and you cannot talk about one without talking about the other. They have a bidirectional relationship. And so we see that if you're experiencing mental health symptoms, you are likely going to self-medicate with alcohol and drug use. We also see that alcohol and drug use can exacerbate mental health symptoms and make mental health disorder symptoms worsen. And then they also have similar, and we will get into sort of the predictors of mental health and substance use among youth, and they are almost identical for mental health and substance use issues when we think about sort of the socio-ecological predictors of both of these issues. So what is the scope of the problem in Mississippi? So I've provided some comparisons between what's happening in Mississippi, what's happening in Region 4 of the United States, which includes the southern states and the Southeast, and then what is happening in the US broadly. And a misconception that we see is substance use does actually tend to be lower in the South. So oftentimes people are like, this is great, we're doing great, right? Like everybody, all those problems are elsewhere. So I want to kind of look a little bit and dive a little bit deeper into that. So yes, when we lump everything together, when we just look at alcohol use, when we just look at all drug use together, we are doing relatively better, right? So you see that we have about on par for any alcohol use and lower than our national average. Same for binge alcohol use. Tobacco product use is, and this is amongst 12 to 17-year-olds, it's about the same. Any illicit drug use is also about the same, a little bit lower than national averages. Mental health, we see that sort of similarly. We see that we're about 19% of our adolescents have experienced a past year major depressive episode, similar to the region, a little bit lower than the US. And then attempted suicide is about on par. But what I want to do is I don't want us to be fooled by these statistics and to kind of rest on our laurels and say like, well, we got this, right? Because we are not doing well when we start to actually pull out these different substances. So if we don't just lump all substance use together, but we say, what are the things that we need to focus on here in Mississippi? So if we start to compare, and I have information for both 12 to 17-year-olds and then also our 18 and older population. Tobacco use is a place where we are not doing well. So we see that for our 12 to 17-year-olds, we have higher rates of past month use. And then in our 18 and older, that jumps even higher. Some interesting things that I want to point out. Methamphetamine use, and this has gotten a lot more attention lately. As a researcher, I've been seeing a lot more grant opportunities at the federal level pop up for methamphetamine use. And in Mississippi, this is a growing issue. So if we pop that out, you can see that Mississippi is slightly higher in our 12 to 17-year-olds and is actually the highest prevalence compared to other states in the South and is higher than our national average. But then if we look at 18 and older, we see that that gets even worse. So we're seeing that these problems are starting in adolescence, but then it's getting even worse when we get to our 18 and older population. This is the exact same thing that we see for opioid misuse. We're doing about the same for our adolescents, and then all of a sudden we spike and we're higher than the national average and we're higher than the region. we see the exact same trend in opioid use disorder. About the same kind of dancing on that line, and then we shoot way up, right? So what is happening here? What's happening is that maybe we're pouring money into adolescence, but we're not sustaining programs past high school. We're not thinking about our university students. We're not thinking about the growing number of students that are choosing not to go to a four-year college. We're not providing support at community colleges. We're not providing support for those that go directly into the workforce. So we need to give them skills in adolescence to not initiate substance use so that they can carry them into adulthood. So maybe you're someone that was not introduced to substances in adolescence, but that doesn't mean you have the skills to go to college and not use them then. So we need to look at this and say, what are we carrying from youth and adolescence into adulthood? So why do we care about this issue? Because there's a lot of associated harms and a lot of harms for our state in general. So we saw that there's about 400 suspected overdose deaths in Mississippi in 2023. This was a 10% increase in 2022. This is awful in itself, but we actually saw for the first time since 2018 a national decrease. So overall, there was a national decrease in overdose deaths, but Mississippi had an increase. So we are moving opposite to the rest of the country. About 75% of the deaths were opioid related, and about a third of drug overdose deaths in 2020 were among people younger than 35. We see a huge economic impact of substance use disorders. A lot of that's related to just the cost on our social services as well as our workforce. And then other consequences linked to this are crime and violence, motor vehicle crashes, and obviously healthcare costs.
So, excuse me, we've talked a little bit about ACEs, and we will talk more about ACEs because we can't talk enough about ACEs. But some of the factors that can lead to mental health challenges or shape the mental health of our youth are really multifaceted. We look all the way down to the individual, race, disability, but it really extends all the way through the family unit, our community, our environment, and our society as a whole, where that's where governmental policies come into play and can help us to impact and shape the mental health of young people. So we've talked about ACEs. Like I said, we're going to talk about it till we can't talk about it anymore. So we do show that ACEs, exposure to adverse childhood experiences, which we will discuss here in a second, do increase mental health challenges for our youth. Now, Mississippi is trying to make some strides in the right direction for that. I was reading just the other day that we have a task force for ACEs. So we understand the importance of childhood experiences and how that can shape our youth. So we are doing something to address it, which is good because according to the CDC, 61% of adults had exposure to at least one ACE and 16% or more experienced 4 or more ACEs. Now, Mississippians are disproportionately disadvantaged or exposed to ACEs when compared to the rest of the nation. But some of those outcomes of ACEs include mental health challenges like depression, anxiety, PTSD, and substance use disorders for sure, but chronic physical health impairments such as diabetes and high cholesterol, heart disease, these are all chronic health issues that are a direct result of ACEs. So what are ACEs? Adverse childhood experiences. Of course, we can conceptualize abuse and neglect. Like we get that, right? The children are being mistreated. They're not getting the things that they need, but also some household challenges, including substance misuse within the household, mental illness in the household, things like divorce and separation. Anytime the family experiences a tumultuous time, that impacts the child. Incarceration of family members. That is something we're seeing with our kids in the JRC, is that a lot of their adverse childhood experiences include incarceration of family members. So how do we begin to help heal the communities and heal the families where this is happening? And then intimate partner violence or domestic violence. Other adversities can include bullying, community violence. Anytime there's crime or violence in the community, that is an adverse experience for these children, and it does shape how they handle those mental health challenges. Natural disasters, refugees or witnessing or experiencing acts of terrorism can also be adverse childhood experiences.
Okay, so we're going to end with some solutions, and this is based on the research. Obviously, we're huge proponents of doing what is backed by research and practice that has been shown to be the best solution for the particular issue. So once again, I'm going to speak about 3 recommendations that are more linked to public health and policy, and then Dr. Montgomery is going to speak a little bit more about approaching it from a treatment healthcare point of view. So as we saw in that socio-ecological model, oftentimes we tend to live in the individual realm. We tend to just treat the individual and we're ignoring what is happening above in those other levels. So as a public health person, I'm always saying we got to go to the community, we got to go to the society. What is happening that's trickling down and making the individual sick? So my first recommendation for this task force is we have to address the economic and social barriers that contribute to poor mental health. We don't even have to pass policies that mention mental health, but we will see an impact on mental health just by focusing on things like ending child poverty and ensuring access to quality childcare, early childhood services, education, healthy food, stable housing, and safe neighborhoods. If a student is getting an amazing experience with their school counselor, but they are still going home to an unsafe neighborhood, they're still going to have mental health issues. So we have to look at the holistic child, the holistic youth, the holistic young adult. We also have to make sure that we are coordinating beyond just our legislature. So for example, we have to look at our administrative agencies and whether or not they're operating to also ensure access to these things. So for example, we need to ensure that eligible households are receiving the services. Let's not just create them and then stop there. Let's make sure that the people who need them and who are eligible for them are getting them. The second one is this is where we have to focus on health insurance. And this has definitely been also in the other speakers as well. They mentioned this and I will harp on it till I retire. So we have to ensure that all children and youth have access to comprehensive and affordable coverage for mental health and substance use issues. I think Mississippi is on the right path. I really do. I was incredibly inspired to see the conversations that happened in our legislative session around getting at that treatment coverage gap we have and looking at how we can expand Medicaid. Like a lot of people follow sports, I follow health policy bills. I was like on the edge of my couch being like, we got this, we can do this. So I'm really excited to see that those conversations are happening. And I do believe that we can get there because that will immediately affect our kids and our youth for behavioral health. So accessing outreach and enrollment resources. So if we already have existing Medicaid and CHIP programs, let's make sure that we are enrolling people in them. There are people that are eligible and that we will cover that are not enrolled. So we need to make sure that they are enrolled. We also need to support those programs to develop and implement behavioral health resources. Let's not just get them enrolled, let's make sure they're having quality access to it. So once again, it's that whole spectrum. And we cannot forget about our most high-risk youth. So when we say all youth, we have to mean all. So we have to look at our high-risk groups, and the 2 that come to mind are our youth that are in our juvenile justice system and those that are in our child welfare system. And my third is taking an upstream approach. So in public health, we have a parable that we always tell our students, and that's if we just stand downstream and wait for people who are drowning to come down and pull them out one at a time, it's exhausting, it's time consuming, and it's expensive. And no one ever thinks to just walk up to the upstream to the top of the river and see what is throwing them in. And if you just fix what's throwing them in, you don't have to stand at the bottom and pick one person out. So our counselors right now are just pulling out one at a time, and public health wants for us to go upstream and just stop what's throwing them in. So we need to be able to pass policies that do that. So how do we do that? We use people like the William McGee Institute and like our COPE folks, and we need to make sure that we are having good public health programming, so that prevention piece that my other colleagues have talked about today. So we need to implement and evaluate evidence-based programs. We have a lot of programs that are in schools right now that do not work. DARE was in our schools for decades, and it is not a good program. And there was so many schools and governments that just threw money at it and it did nothing. So we can't just get money. We have to put it into programs that actually work. And the people who evaluate those are people like me and researchers. So we need to hire research teams and give them money to evaluate programs and policies that are in place. The programming has to start when children are young, and it needs to sustain into young adulthood. And we need to move beyond decades of things that we've been doing that do not work. We need to also build community-wide efforts. Oftentimes, anytime we're talking about kids, we say, just give it to the schools, right? Put it in the curriculum, give it to the school counselors. I don't think they need or want anything else to do. So we have to come up with other things to do. We have to hire community health workers, public health professionals, social workers to build community-wide efforts. And we have to understand that Mississippi is very diverse, and what's going to work in Lafayette County is not going to work in Simpson County, is not going to work anywhere else. So we have to go to the communities and say, what do you need? What's going on here? And what can we do that's catering to what works for this particular area? When we have to have end-to-end support, how do we pick the programs that work? How do we implement them? How do we evaluate them? And then how do we improve them if we see that they're not doing anything? And then we also have to look at the existing legislative barriers that we might have. So for example, we have laws on the books that are preventing us from being able to use really good harm reduction policies. So let's take a look at what we already have and say, what is not serving us? Because if we remove some of these, we will see improvements. I know we will see improvements because in states that have these programs in place, they've seen improvements. So before I pass it back to Dr. Montgomery, I just think this is a very interesting report. So Trust for America's Health, this is older. So I think that Mississippi has made a lot of good progress since then. This was in 2015. What they did is they came up with 10 different indicators for laws that legislatures could pass related to adolescent mental health. So for example, passing policies that support academic achievement, preventing bullying, preventing underage alcohol sales, Good Samaritan laws. And they looked at every state, does this state have that type of policy on the books? And then they gave that state a score from 0 to 10. How many of these policies did they have? Mississippi at the time had 3. We had the lowest amount of these policies in place to prevent or address youth mental health. So I know that this task force wants to do good work, and this is how we do it. We look at what's working and we see we can pass these policies. We can use that list of 10 as a place to start. What do we already have? What can we do better on? What can we enhance? And we can raise that score.
Some of the ways that the University of Mississippi is already working towards some of these improvements include improving access and connection to services across the state. Like I said, we have free telemental health counseling and free in-person counseling. What this does is it serves to fill the gaps that we were talking about earlier with people who are overworked, underpaid, burnout. They just have these huge caseloads, but we have interns who are eager to get out there and get their feet wet and learn how to provide those services for free. We're also offering high quality services in our programs. One of the incentives to go to school counseling is that they can get their dual track license. So they can be school counselors and take all the courses they need to be able to apply for their LPC when they graduate. So they have that option. We also use evidence-based treatments, including but not limited to CBT interventions and psychoeducation. We believe that the more people know, the more tools we put in their hands, the better they're going to be able to fend for themselves and make good decisions. And workforce development. We know that there is a lack of counselors in the state, and we are working to incentivize people to come get their master's in counseling, to stay in the counseling profession, to be able to learn how to be advocates in their community. That's one of the things that COPE does also is we go to outreach events and we teach our students how to be advocates. We teach our students some of these issues that we've been talking about today with substance use and how it impacts their communities. So we are working to develop a workforce with UMMC and with our interns just to be able to fill in those gaps.
So we just want to end by sort of solidifying our dedication at the university. And we know that we're not the only departments, centers, researchers at the University of Mississippi that are engaged in this work. So we want to make sure that we're covering multiple sectors. So including researchers like myself, policymakers like our state legislature, healthcare professionals like our counselors and those at the COPE Clinic. So we are equipped to do this work, but like everyone else has said, we need the resources, the money, and the support to do that. And so several of the things that people were talking about, like who could maybe go and do trainings, we will do them, right? So like, if you say like, oh, we want to do this state program wide, send it to us and I will implement it and I will evaluate it, right? So all of that, like we are here, we want to do this work. Once you guys decide what those best practices are, what you want to do, or you need insight, we want to implement it, we want to evaluate it, and we will do it. And we will fill in those gaps that our current workforce has. So we appreciate it. We do have our contact information, so we hope that we can kind of keep that door of communication open moving forward.
I think you have opened everything up with questions first. So are there any questions from the group? Representative Creekmore.
First, I want to thank you for the Medicaid expansion comment.
I have to do it. I have to. I have to say it.
You mentioned in your potential reasons for some of these problems was the growing use of digital media. And in the last hearing, we discussed at length about cell phones in schools and the social media platforms that they have access to. And we also talked about the book Anxious Generation, which concludes that they should not be allowed in schools. Do y'all, and during your research, do you have an opinion on that or any thoughts?
Yeah, I think that's the right direction to move in, because the research that we've seen on the links between social media and mental health, none of it is positive. So even students that are engaging with maybe more positive accounts, so we have seen like movements towards more like body positive accounts or pro mental health accounts. It's not saturated enough that it's getting rid of the negative pieces that they're being exposed to on social media. So I think if we can use school policy as a mechanism to cut down on social media use, I think that is positive. Yeah.
All right. And you mentioned we have laws in place that prohibit you from using some harm reduction policies that specifically, can you tell us what that is?
Yeah, so the one that I listed was currently in Mississippi, our legislation doesn't allow us to do like syringe services programs. So for example, in state, so what those do is they allow like needle exchanges, and for injection drug users, they are able to go and essentially use drugs safely. And I think that the overwhelming amount of states that have passed and policies that allow for the implementation of safe syringe programs have seen a reduction in overdose deaths and negative outcomes associated with injection drug use. I think that there is a myth that by allowing policies like that, we are encouraging drug use. It's the same as the myth that if we teach safe sex education, it encourages people to have sex. It's not the case. So we need to make sure that we are looking at kind of what's on the books and how can we look at harm reduction as opposed to a zero tolerance or an abstinence approach to substance use amongst our youth, because it's not realistic, and see like what is preventing us from being able to do the programs that we might want to do.
If I can add to that, one of our CHAMPS program at the Oxford School District, they came up with an amnesty box idea where if they wanted to turn in their vapes and their vape paraphernalia to a box in the nurse's office, they were allowed to do so, no questions asked. And what they found was self-reports from the students that they had drastically reduced their vape usage. So we're seeing something very similar that's working in the school district there.
Well, thank you so much for being here. Again, I think your insight has been very beneficial. And so to try to stay right on time, I think we're right on 4 o'clock. We're going to move to our last group of the day. And this is our first, during these hearings, attempt to do virtual via Zoom. Senator Bryan, we will see how this works. I see you're already leaving. So I'm expecting, so I assume you're not expecting this to work very well. But, and there goes Dr. Edney. No, but really, if you remember last time, what we wanted to try to get some handle on is we wanted to try to find out a perspective of what action steps have been taken by other states. There was some mention in the last presentation about what other states are doing, and we've done some looking into that. So we reached out to our partners at NCSL, and I thank our staff for helping put this together. And so via Zoom, we have Flora, I may mess up the name here, Falati, Policy Associate, and Tammy Hill, Project Manager in the health program from NCSL. Hopefully they will be coming on screen with our tech department here. And what we've been doing, I've been noticing that you've been tuning in, at least for a little while here. We've been allowing you a little bit of time just to introduce yourself and then just to go into your presentation, and because we have both of you, we may have you, work that in tandem as best you can, maybe one first and then one following that. So if we're able to do this, let's see if we can have Flora come on first and give us some perspective on her part. So Flora, are you there?
Yes, I am. Can you hear me okay in the room?
We can. I think we have your presentation up on the screen and we can hear you pretty well, surprisingly.
Perfect. And you got my name perfect. So if my presentation is up on the screen, I'll get right into things. So thank you to the task force for inviting me to speak today. And I will be the only one presenting. My colleague is on the line, but I will be covering the presentation. First and foremost, my name is Flora Filati. I am a health policy associate at the National Conference of State Legislatures. I work on child and adolescent health policy, including youth mental health, and I'll be providing a national overview of recent youth mental health legislation across the states. And so before I get started, let me quickly introduce NCSL and the work that we do. For those of you not familiar with us, NCSL is the country's trusted bipartisan organization serving legislators and staff for almost 50 years. Listed here are a few of the services that we provide to state legislatures. And as we dive in, I did want to note that any of the policy or state examples that I will reference today are purely for informational purposes. NCSL does not advocate for or against any state legislation, and we do not create model legislation. And so the reason we are here today is to talk about youth mental health. And I'm sure what the speakers before me have discussed, as well as your constituents and community members have said, is that we are in a crisis of youth mental health and our young people are struggling. And youth mental health is so key because 50% of lifetime mental illness begins by age 14 and 75% by age 24. And we know through the tracking here at NCSL that over 80 bills were enacted in 2023 related to child and adolescent mental health, and over 100 bills have been introduced this year so far just on mental well-being of students and staff in K through 12 settings. But we're asked is, what does this mean? And what can I do? Or what are other states doing to prevent and intervene on this health challenge? So the strategies to address youth mental health are broad and varied, but in our legislative tracking, we've seen them land in around these 5 buckets. We've seen legislation around early screening and intervention, school-based services, workforce supports, suicide prevention, and access and coverage of mental health services. And for the purposes of this presentation, I'll be talking about those 5 categories, and I'll be walking through this by age group. I'll be starting with early childhood and lower school, so up to the age 10, then middle and high school, 10 to 18, before concluding with post-secondary, so young adults ages 18 to 25. And so without further ado, I'll start with some of the levers we've seen around early childhood and lower school. A recent study of parents with children ages 5 to 12, 22% reported overall worsening of mental or emotional health. And we know that early childhood brain development is remarkably key in terms of long-term physical and mental health across the lifespan. And so when we look at state legislation around this age group, we see a fair amount focused around early care and intervention, specifically surrounding primary care. We've seen that Rhode Island established a state plan to improve the promotion of social and emotional well-being of young children, that including screening, assessment, diagnosis, and treatment of mental health challenges through their Medicaid program for infants and young children under the age of 6. And Arkansas added supplemental reimbursement rates for preventative services for children to support positive mental health, also through their state Medicaid program. This legislation in Arkansas came out of their 2022 Mental Health and Behavioral Health Working Group. This working group provided a broad scope of recommendations, but one of the recommendations included in that working group was incentivizing medical homes to address prevention and early intervention through universal team-based enhanced primary care services for children. And because I joined this call a little early, I know that you have already talked about adverse childhood experiences, and so I'll breeze through ACEs very briefly. ACEs being potentially traumatic events that occur in childhood. We included some examples on this slide. And according to the CDC, 64% of adults in the United States reported they had at least one ACE before age 18, and 1 in 6 had reported experiencing 4 or more. And ACEs can negatively impact children's brain development, immune systems, and stress responses, and these can have long-term impacts on mental and physical health into adulthood. So we are seeing some state legislation specifically around preventing, mitigating the impacts of trauma, or building resiliency at young ages. 2 examples of these is we saw that Illinois created a healing-centered Illinois task force to advance Illinois' aim to become a trauma-informed state. And we saw that Indiana provided that Department of Child Services may use a child advocacy center to coordinate multidisciplinary teams when responding to reports involving child abuse or neglect. So again, these are some examples of legislation we're seeing to mitigate long-term impacts of trauma for that early childhood mental well-being. And now we'll move into middle and high school, which is where we see the bulk of state legislation around youth mental health. CDC collects data on youth risk behavior, and I can actually say that CDC released their newest round of data just yesterday. So this is actually not the most up-to-date CDC data. But previously, there were reported 42% of high school students experiencing persistent feelings of sadness and hopelessness, 22% seriously considering or attempting suicide, and 18% had made a suicide plan. According to the most recent data coming out of CDC just yesterday, there are some improvements in some of these areas, largely returning to 2019 rates, specifically regarding persistent feelings of hopelessness. But again, even returning to 2019 rates, these are very high prevalence amongst young people. And we know that there are strong disparities and impacts amongst different populations, specifically worsened outcomes for Black and American Indian and Alaska Native folks, as well as for young girls, meaning that these impacts can sometimes be compounded for adolescent girls of color. And so we see schools as a common lever when addressing youth mental health. But in a survey of public schools in 2022, roughly half said only half agreed that they could effectively provide mental health services to all the students in need. And so we are seeing some focus in legislation around preventative services of including mental health in school health curriculum. Some examples of these, although this is not exhaustive, is New Jersey required school districts to include information on symptoms of grief, coping mechanisms, and techniques for handling grief and loss. Utah collaborates with the University of Utah to create mental health guidance for their school health curriculum. But another area that Utah recently added as an aspect of their mental health curriculum is digital citizenship. So they created their Digital Wellness, Citizenship, and Safe Technology Commission to advance the goal of training every student in healthy behavior related to technology use. And they define digital citizenship as including digital literacy, ethics, etiquettes, digital security, and they also collaborate and coordinate with efforts related to cyberbullying and suicide prevention. And then Oklahoma recently added mental health instruction to health education and allowed school districts to partner with approved nonprofits and community partners as part of that mental health instruction. Another area we've seen state legislation is for opioid antagonists in middle and high schools. For those familiar with opioid antagonists, you may have heard of naloxone or Narcan, and they can prevent death in the event of an overdose. Median monthly overdose deaths amongst adolescents ages 10 through 19 increased 109% from 2019 to 2021, and approximately 90% of those deaths included opioids. Colorado recently encouraged schools to implement a policy to furnish an opioid antagonist on middle and high school grounds. And Oklahoma provided that any school nurse can administer an emergency opioid antagonist in the event of a suspected overdose. We've also seen youth suicide prevention as an area of focus among state legislation. Around 20% of teens have seriously considered suicide, and for middle and high school age youth, meaning 12 to 18, suicide is the third leading cause of death. A few pieces of legislation we've seen in this area is from Connecticut, which added that boards of education to include the 988 National Suicide Prevention Lifeline on student ID cards for grades 6 through 8. And Louisiana added criteria if a school to be certified as a suicide prevention certified school. And the school board maintains an updated list of such schools on their website. And the legislation goes on to elaborate on what schools must meet to hit that criteria and what programs must be involved to be a suicide prevention certified school. And I overheard this being brought up earlier, but we are noticing as an emerging area of state policy is regulating the use of personal technology in schools. Now, when I say personal technology, I am primarily referring to personal cell phones, but some legislation in this area may also be referring to iPads, laptops, or other types of technology a student is bringing in from home. Recent data suggests that adolescents ages 13 through 18 average around 7.5 hours of screen time a day, including TV and video, gaming, and social media. So we are seeing some states look into regulating cell phone use in schools, both for learning outcomes and longer-term mental health outcomes. Georgia requires local boards of education and governing bodies to submit acceptable use policies and technology protection measures for review by the State Board of Education. And just recently, Pennsylvania created a pilot program that would allow schools to opt in to a restricted cell phone policy. The policy would be that students, when they come into school, would put their cell phone in a lockbox and then get their cell phone out of the lockbox at the end of the day. Again, this is an opt-in program, but for schools that choose to opt in to this restriction, they would receive a grant from the state for the purchasing of that lockbox. And school-based mental health services can improve access to care and allow for early identification and treatment of mental health issues. It may be linked to reduce absenteeism and better mental health outcomes. School-based services can also reduce access barriers for underserved populations, including children from low-income households, rural communities, and children of color. Since COVID, the use of telehealth has evolved, expanding services and increasing access by broadening the definition of an originating site and the type of healthcare professionals who can provide services. Effects and use of telehealth continue to be studied in this space, and a recent study in North Carolina suggests that the use of telehealth in school-based healthcare may reduce absenteeism. Looking at some state examples regarding originating site, Georgia expanded the definition of an originating site, which is where a patient is located when they receive services via telehealth. And Georgia expanded to include a patient's home, workplace, or school, and requires private insurers to cover audio-only telephone consultation for mental and behavioral health services. And then for examples related to authorizing additional practitioners, Maryland authorized that a healthcare practitioner at a school-based health center can provide services through telehealth, including primary care, preventative care, and behavioral health services, which can enhance the connection to behavioral health supports and specialists. In Florida, it required each school district to implement a mental health program that includes, among other things, contracts or agreements with community behavioral health providers to provide services at schools, including via telehealth. In Massachusetts, they appropriated funding for a pilot program for telebehavioral health services through schools. And as some of you, I'm sure, are aware, workforce challenges can pose a barrier to accessing adequate mental health treatment in and out of school. One approach to addressing limited youth mental health workforce is increasing the amount of professionals who can provide mental health support. For example, Colorado created a program to provide high-quality training resources and implementation sustainment support for educators to provide evidence-based mental health services to students. And then another approach is to expand the amount of professionals available that are trained in the medical profession to be able to provide mental health services. For example, Iowa provided at the University of Iowa Hospital and Clinics to begin a state-funded psychiatry residency and fellowship program, which would serve to increase the total number of psychiatry residencies within the state. And then we've also seen crisis response as an area of priority among state legislators. From 2007 to 2016, pediatric mental health emergency department visits in the US increased by more than 60% at all hospital emergency departments and increased by more than 120% at children's hospitals. Two approaches that we've seen related to crisis response in Hawaii, they established a 2-year child and adolescent crisis mobile outreach team pilot program on Oahu and another neighboring island to expand their existing crisis response services. And then for young people experiencing severe mental health crisis, in some ways, or in some cases, the first state department they're interacting with may be the juvenile justice system. And so another response we sometimes see related to mitigating harm around crisis response is training law enforcement officials to be able to recognize possible opportunities for referral or possible needs in that moment. Indiana required each person training at a law enforcement training school to include 6 hours of training in interacting with people with autism, mental illness, addictive disorders, and intellectual disabilities. And related to crisis response, we've also seen many states look at their available resources related to youth residential care. We saw Maine require their Department of Health and Human Services to submit reports to the legislature on children's psychiatric residential treatment facilities. New Hampshire created a commission to study the behavioral health crisis programs and also limited pre-authorization requirements for emergency behavioral health services. We also see in some states concern around the amount of young people needing to travel outside of the state in order to receive adequate psychiatric residential services. And so Montana created an enhanced Medicaid reimbursement rate for certain in-state children's mental health providers for psychiatric residential treatment. And this was specifically with the intention to encourage young people who need this level of care to stay within the state and not have to travel outside of the state for care. In Illinois, there was a focus on some recent legislation around youth in state custody, so youth in foster care. And Illinois required the Department of Children and Families to develop a strategic plan to improve the timely access of quality residential in-state treatment. And like I said, that specific legislation in Illinois was focused on children in state custody. And something that has been brought up a few times in my presentation, and I overheard brought up in previous presentations as well, is that for children with mental health concerns, they don't only interact with the health system, they also interacting with the school system, the juvenile justice system, the child welfare system. And so we've also seen states look at interagency collaboration and cooperation. To bring a few examples, Louisiana created the Community Responder Task Force to study the implementation of a partnership between law enforcement agencies, behavioral health providers, and hospitals. And Connecticut established the Transforming Children's Behavioral Health Policy and Planning Committee to evaluate the availability and efficacy of prevention, early prevention, behavioral health treatment services. And so lastly, I'll be talking about post-secondary age. So this is ages 18 through 25 young adults. In 2021, there were estimated 57.8 million adults aged 18 or older in the US with any mental illness. And this number represents 22.8% of all US adults. And around less than half received mental health services in the past year. Young adults aged 18 through 25 had the highest prevalence of any mental illness compared to any other adult age group. And around 40% of 18 through 25-year-olds are enrolled as undergraduate or graduate students. So we do see post-secondary school as a lever for this age group. Although mental health services often vary on a school-by-school basis. But two policy levers we do see applied statewide in post-secondary schools are similarly around opioid antagonists and suicide prevention. So the Massachusetts required institutions of higher education to make opioid antagonists available for the purpose of treating overdoses. And Wyoming clarified that the University of Wyoming and Wyoming community colleges may receive a standing order for opioid antagonists if the entity develops a drug overdose treatment policy, and the legislation goes further into what must be included as part of that drug overdose treatment policy. And surrounding suicide prevention, we see that Maine and West Virginia both enacted legislation on having state IDs for institutions of higher education to include the 988 telephone number for the National Suicide Prevention and Crisis Hotline. And for schools that offer mental health treatment, we've seen Colorado, West Virginia, Tennessee, Texas, and Utah recently enact bills related to information sharing about mental health support for students. Specifically in Texas, they require that institutions of higher education must include a campus map identifying any location that mental health services are provided, as well as instructions on how to access those services. And even among students enrolled in post-secondary school, adults in this age range may receive their coverage from other public or private insurance and may struggle to access adequate mental health care in the adult mental and behavioral health landscape. I could be here for another few hours to talk about all the various policy levers around access to care in the adult population for mental and behavioral health, but to highlight two policy strategies we've seen to improve access to adult mental health supports. Wisconsin provided reimbursement for peer recovery coaches under Medicaid, and research has found that patients receiving peer support services are less likely to be readmitted into a hospital, spend less time in inpatient care, and have lower overall cost of services than those receiving standard care. And we saw recently in Minnesota, they required mental health therapy visits and medication maintenance visits to be considered primary care for the purpose of cost sharing requirements. And so to close us out, for the variety of policy strategies that have been looked at across the 50 states, I want to leave you all with a few key takeaways, which is that prevalence of mental health conditions and disorders remain high for children and adolescents. States are leveraging a variety of settings to address youth mental health concerns, and that includes primary care and school settings. And state legislative policies aimed at improving youth mental health in schools vary widely, but generally focus on a few key areas, including but not limited to early intervention and prevention, mental health education and training, school-based health services, telehealth, and crisis intervention. And so that's all I have for you today. And thank you again for inviting me to present on state strategies to address youth mental health. I'm happy to answer any questions, or feel free to reach out to me directly by email. I've also included some of our resources on youth mental health, as well as some other topics mentioned in my presentation, including our maternal and child health database, which includes tracking on youth mental health services in schools and outside of schools, and also some resources from our education program on student mental health supports. I'll be happy to take any questions.
Thank you, Flora. I have one just question here. You included in here the cell phone issue. I know I was at another meeting about 2 weeks ago with some people from Louisiana, and I think they just recently passed a change in their cell phone policy for their schools. And the legislator I was speaking with, and I don't see that listed in your handout here, expressed the statement that there was not a huge amount of opposition from the parents, at least in that state. Do you know, or could you provide any, I think we now have, I think it's maybe 4 states that have implemented a policy recently or changed a policy. I was hoping we could get some information on what those policies are in other states, and also from you, how those policies, when they were presented, were viewed by the state, and any takeaways that could be problems or positives as we consider some policy initiatives there. Do you know, or is that something you can get for us?
It's absolutely something I can get for you all. The examples I provide are not necessarily exhaustive, but we are aware that a growing number of states are looking at restricting cell phones within the school setting. It is something we've done some recent legislative tracking on, and so I can certainly follow up with you on where the current national landscape is at regarding restricted cell phone use in schools. I will mention that for the ones we are aware of, they are generally in the very early planning or implementation stages. So I don't think we yet have outcomes related to how these have panned out or how the implementation is looking, as it is a very recent, new, emerging area of legislation. But I'd be happy to reach out with a list of states that have currently worked on it, and as well as link directly to some of that bill language.
Yes, and I do think it would be beneficial for us to see basically if any legislation has been passed, what it looks like. So that would be of help too. And I'm gonna open this up to the committee here too. So because most of you maybe are not as familiar with NCSL and their role, is the hope in having them as presenters were that anything we're thinking about implementing, if another state has done that, trying to find out if there is a policy out there, or if there is, a success or a failure out there that exists on a particular issue, where they could maybe help us get some wording or some guidance in that direction. That was the intent of having them present here. So just based on what we've heard so far, are there any statistics or any other numbers that we would like to have NCSL try to put together for us on any particular issue? Or, because I do think out of the last meeting, that, what other states are doing on the cell phone was something that I know we wanted feedback from Dr. Evans on, and we wanted other feedback. So I expected that one. But anyone have any other task? Yes. Can you hear, Flora?
Hello.
Oh, I can hear now.
Yes, I would appreciate the opportunity to have any data that's available on prevention programs at the collegiate level, perhaps which ones are most impactful, where we've seen the best results, and looking at some of the cost benefits and the ROIs related to suicide prevention programs that you have seen to be effective in. On the counter side of that, those that are less effective. We talked earlier about a lot of money going into a program like DARE and not really seeing the statistical impact. So I'd love to know what's real and what's making a difference when we look at, if there were dollars, where to spend them on the collegiate level. Thank you.
Absolutely. That's something we can look into to see if there was some post-secondary, so undergraduate or graduate level look at return on investment for prevention, specifically suicide prevention.
And we have our youngest member with some inputs. This is very important. So listen close, Flora.
Hello, thank you so much for your presentation. I have 2 questions about two policies. One you mentioned, and one that I don't think you mentioned. I might have missed it. But the first one, you mentioned that in some states they've implemented curriculum in their health classes around mental or surrounding mental health. And I was wondering if there are any states in particular that were most successful with those policies. They saw, great outcomes with those policies.
Absolutely. It can in some cases be difficult to draw to specific legislation on these early stage prevention strategies, those health class curriculum that are taking place in lower or middle school and tracking exactly what is responsible for long-term impacts. But we do have some research on which types of prevention mechanisms or which types of curriculum are associated generally with positive impacts. And that is certainly something that I can follow up with you on.
Awesome. And then the next thing, I don't think this is something you mentioned, but do you know of any states that are have implemented uniform mental health screening in grades K through 12? And has that had positive outcomes?
Yes, I didn't mention screening in my presentation, but it is something that we've seen some legislation around. I will mention that screening is often included, especially for the Medicaid population, as part of the ESPDT benefit. But we, off the top of my head, and again, this is something I can certainly follow up with you on with a much more exhaustive list. I am aware that Colorado has looked into universal screening as a program. I believe starting at age 12. It's something that students still can opt in or opt out of, but I believe Colorado has somewhat recently enacted legislation regarding universal mental health screenings.
Yes, ma'am. Thank you so much.
Any other questions or comments from the committee? Okay, if not, thank you, Flora, for the information, and thank you for being willing to look into I think we have about 3 or 4 little action items that if you could get us feedback on would be greatly appreciated. So thank you and your team for taking the time today.
Absolutely. Thank you all.
Okay, so I think we're pretty close to on time here. So the challenge of this, I think, is that sometimes we have presentations that get us a lot of information. Some we get more questions from the presentation, and certainly that was my case today. So tomorrow we have, a little different perspective coming up. You can look at your little syllabus and see who we've got coming tomorrow. But in just as far as topics go, and I'll just open this up for a comment on this, but as we've looked at presenters and we've looked at information, are there in particular any areas or presenters as far as subject matter that anyone feels that we have been lacking in so far? Yes.
I think that we've done like a great job of covering all the bases as far as like K through 12 and post-secondary mental health resources and areas to improve. But I was just wondering, like, starting to look into like what policy implementation would be like. Like I know several people have asked, like, what would it cost to do this? What is the return on investment? Things like that. I mean, obviously maybe looking at other states, but just something like that.
So maybe a fiscal kind of analysis on it, Deborah. Something we could kind of try to look into finding a presenter on. Any other suggestions on that topic right there? Yeah, so the thing we'll do here is, because it's late and everybody's tired, it's hard to sit here and listen to presenters for a long time. Good news tomorrow is presenters don't last as long. I will mention, that my sheriff is coming tomorrow, and hopefully he will offer a new perspective. And then if you will tonight, just take a little bit of time, because again, you have 5 minutes tomorrow or so. You may have a little more than 5 minutes if there's not a lot of need to present, but just some takeaways that you see that we need to kind of get from your background or your experience included in the minutes and the direction of the recommendations we're trying to put together. So just work on that a little bit tonight. And then we will also be looking tomorrow at our next meeting date. Just be looking at your calendars. My intent will be to probably find a couple of days like we did this time, another Wednesday, Thursday type of scenario. So be looking at your calendars on that. We'll give that some discussion tomorrow. And beyond that, let's go ahead and adjourn until tomorrow if there's a motion. I'll see you all in the morning. What time is it, Deborah, tomorrow? 8 a.m. tomorrow.